Ontario is set to spend more than $53 billion on healthcare this fiscal year. That's the largest single item in the Ontario budget, of course, and still there are calls for more and more spending. That's part of what's got doctors talking about overtesting and overutilization of procedures that can be costly to the system and to patients. Joining us now for more, Dr. Michael Schul. He's President and CEO and Senior Core Scientist at the Institute for Clinical Evaluative Sciences. Dr. Danielle Raza, Chair, Canadian Doctors for Medicare and a family physician at St. Michael's Hospital in Toronto, and Dr. Wendy Levinson, Chair of Choosing Wisely Canada and Professor of Medicine at the University of Toronto. And we are delighted to welcome you three around our table here at TVO tonight. Just to set up our conversation, let's bring these numbers up if we can, Sheldon. This is from Choosing Wisely Canada and CIHI, the Canadian Institute for Health Information. Canadians have more than 1 million potentially unnecessary medical tests and treatments each year. Isn't that a stark figure? That is up to 30% of medical care that Canadians receive potentially being unnecessary. Unnecessary care wastes health system resources, it can increase wait times for patients in need, and it can lead to patient harm, physical harm, greater levels of stress for patients and their families, and false positives, all of which we will get into as we go through our conversation here. Dr. Levinson, get us started here. Give us an example of tests that are needlessly given that we don't need.
Sure. Well, I mean, there are many common things. There are drugs that we don't need, like antibiotics for viral infections because they don't work. Or often you hear about people getting x-rays because they have low back pain or even an MRI. That's another example. And then there are things that we do routinely in the hospital, blood tests or EKGs or chest x-rays that aren't necessarily needed.
We'll find out why these are done as we go along, but I want to find out from you, in the course of your practice, you can fess up here. Have you ever prescribed medicine unnecessarily or done tests that in hindsight you thought they really didn't need to be done?
Yeah, I think everyone who practices medicine across the country is guilty of doing this at some point in their practice. But I think that really behooves us to be really deliberate in heeding the messages of folks like the Choosing Wisely campaign. And it's something that I have a conversation with my own patients. Every time I welcome a new patient to my practice, we have a conversation about my philosophy and my approach to care, using evidence to guide my clinical decision making, whether it's tests or treatments. And a lot of patients might be surprised that when it comes time for their periodic health exam, they don't get a battery of tests. They might just get an age-appropriate cholesterol test or sugar test, or sometimes nothing at all.
So not everybody gets an annual checkup?
Not everybody, not everybody.
Because they don't need one?
Correct.
And when you try to sell that to them, how many of them, when you say to them, this is how I do it, how many walk out the door and say, well, then you're obviously not the doctor for me?
Well, not too many people react that way. Most of the time, when they're meeting you for the first time, when they're your new patient, they know that you have a particular way of doing things. They might be surprised that it's different than the way that doctors might have practiced before. But when you have a conversation and you sit down with a patient and you explain the reasons why you do or you don't do certain things, most patients understand and come around.
Okay, yeah, Dr. Schul, forgive me, I just want to get Dr. Schul in there first. Can you give us an example of perhaps a test that you prescribed knowing that it probably wasn't necessary, but that the patient probably demanded it or would feel better having it?
Sure. I mean, so I still practice in the emergency department at Sunnybrook Health Sciences Center in Toronto. So I see patients all the time. One of the most common scenarios is where I just simply don't have access to the result of a test that's been done before, the same test that's been done before. And if I had access to that result, it might obviate the need for me to repeat the test. Because it's getting better. I think that's the good news, is we are getting better at having access in real time to lab test results or diagnostic imaging tests that have been done elsewhere at other hospitals and clinics, but it's still not perfect.
Can I just understand that? Why, if a test had already been done, would you not, as a matter of course, have access to it?
Because we have not, up until recently, had the electronic systems that would allow immediate real-time access for me as a physician to your lab test results or your imaging results unless they were done at my hospital.
So you have to do it again?
But so in some cases you have to do it again, although as I say, it's getting better now. So, I mean, the good news is recently I saw a patient who came in, a young one with severe abdominal pain and low blood pressure, And I was able to pull up immediately her lab results from a week before that showed that she was pregnant. And that changed, it was very important information in terms of the potential diagnosis. So, there is good news here in terms of our ability to access this, but it's still a work in progress and we still have a long way to go.
You wanted to say?
Oh, well, I was going to say that I think the point about the conversation is very important, because what Choosing Wisely Canada is really about stimulating a conversation between physicians and their patients about, do I really need this test, or is it maybe unnecessary? And I think that many patients are reassured when they have that kind of conversation and the physician understands what their worries are, what they're most concerned about, listens and pays attention, and then really do trust their physician if they say that this test might not be necessary or could even be harmful. The core is that conversation.
I presume that every province tracks what tests are medically unnecessary or potentially medically unnecessary. Do you have any idea where Ontario ranks on that list?
Well, CIHI has provided this data actually for the first time. This report that came out in April that you mentioned, that up to 30% is unnecessary. We have some information that is really just available in some provinces, depending on the information systems, and some that really is available across all of Canada. So it depends on what you're measuring.
Well, let's measure this. Sheldon, shall we bring up explainer number 2 here? This is Province of Ontario data only, where CIHI, the Canadian Institute for Health Information, has discovered that 31% of CT scans in Ontario are potentially unnecessary, almost 1 out of every 3, with nearly 1 in 3 low-risk patients with minor head trauma having a CT scan in an emergency department. That is more than 15,000 potentially unnecessary scans. If you go to the years between 2014 and 15, nearly a quarter of inpatients with delirium had a potentially unnecessary head CT scan. And one more factoid here, in the province of Ontario, more than a third of pre-op tests, that's a chest x-ray, ECG, or a cardiac stress test, prior to low-risk surgeries are unnecessary, potentially harmful, and can delay surgery. The potential cost of this, let me go to you on this. Do you have any idea how much money we're throwing down the drain because of all this unnecessary testing?
I think one of the challenges is we don't really have the highest quality data, which is why this report that you mentioned from CIHI, I think, is such a positive step in the right direction. We often talk about this idea in healthcare reform of the triple aim of doing 3 things all at once. That's reducing costs, improving a patient's experience of their care, and also improving their outcomes, as almost the holy grail of healthcare reform. But it's not such an impossible idea. We can actually operationalize it in a lot of common ways through our healthcare system, and one of them is really tackling this problem of unnecessary care.
Well, let's look at the CT example we just had. If somebody comes in for a CT scan, I imagine there is quite a team that has to be put in place in order to make that happen. So can you start to make a checklist for us of all the people involved and what the potential costs of the whole thing are?
Well, so if a patient comes into the emergency room, for example, with a head injury, they'll be seen by the nurse at triage. They'll then get into the department, see the physician and nurse in the department. But to be honest with you, to order a CT scan is not that complicated a thing. You need to have a technician. They're typically available in any bigger hospital 24 hours a day, and then a radiologist typically to read the scan. So I think one of the things to understand is that the barriers to doing these tests, a CT scan is a complex one, but when you think about lab tests, urine cultures and so on, they're even simpler. The barriers to these tests are actually relatively low.
So is your concern actually less about money and more about something else?
Well, I think this is a complex issue, and it ultimately doesn't just come down to money, right? I think that the Choosing Wisely campaign is not just about saving money; it's actually about providing more appropriate care for people. And when these tests are ordered, it's not, I think, that physicians are looking for ways to waste money. It's that in many cases they may either not understand the clinical guidelines that would say that a test is necessary or not necessary, not be sure whether in this particular case it's necessary or unnecessary, or simply really think they're doing the best thing for the patient in ordering the test. It's a complex dynamic of the physician decision making and what the patient wants. But again, the conversation is key. So, for example, when I see patients all the time who come in and bang their heads, often they're younger kids playing soccer, let's say, and you're talking to the parents, if you take the time to have the conversation and say, look, really based on the symptoms that your child has or that you have, you really don't need the scan. We're not going to do it for the following reasons, because it won't be helpful or it'd be harmful in the following ways. The vast majority of patients are actually grateful to not have the test.
So they don't demand the CT scan anyway?
It's very rare. It's very rare, I will say.
Give us an example, Dr. Levinson, of where an unnecessary test can actually be injurious to a patient's health.
Sure. I think one of the things that people think is that more is always better. We kind of have that in society in general, so they think the same applies to healthcare. But in fact, what's important is that sometimes if you have a test that isn't needed, so let me give you an example. You have a chest x-ray and it's just sort of routine, and they see a little nodule, a little abnormality, and so then they need to do a CT scan, which has excess radiation, and that increases lifetime risk of cancer. So you get a CT scan, and then it isn't quite sure, and they say, well, we better repeat that in a month, and you get another one, and then they say, well, we're still worried about that. We better do a needle biopsy, where they do something invasive. And so you get in what we call a cascade of tests that lead you down the road from an original test that wasn't needed. That's the problem. That's a harm from a test.
But what is that nodule in the first place, though?
Well, often there are little things that are just routinely found that aren't meaningful, and so you chase them unnecessarily. And that really happens a lot if you do 20 blood tests, which we do these batteries of blood tests. It's common that one of them is abnormal just from statistical abnormality. And so again, you can have harm, not to mention the inconvenience of time off work, or discomfort from tests, or stress from tests, worrying about whether the results are positive. So you clearly want these things when you need them, but you want to avoid them if you don't need them, and more is not always better.
What about false positives? How frequent are those?
It really depends on the situation and the test. So it's not, there's no one answer to that. It's very test dependent.
Go ahead. The interesting thing about that example, too, is that the patient may feel, in fact, that having had a chest x-ray that they didn't really need, and then having a CT scan because of a false positive, and maybe even going on to have a biopsy, and assuming that they don't have some disaster as a result of the biopsy and so on, they may feel that they've had fantastic care. They may think I have the best doctor ever because he or she saw something and they really looked into it, and now I'm okay. Whereas if they'd never had the chest x-ray in the first place, they wouldn't have had to go through any of that and would still be okay. So it's interesting how the dynamic can be that you can look like you're being a really good doctor, and in fact these are doctors who are trying to do a really good job when they're doing these tests, but at the end of the day you're actually not doing anybody any favors, and you're costing the system resources and money that could be better spent elsewhere.
Let me follow up on that without trying to seem too personal. When did you go to med school? What years?
I finished in 1988.
1988. Okay,
Long
that's
time
almost
ago.
30 years ago. How about that? All right.
My 30th reunion is coming up.
I'm willing to bet that back in 1988, when you went to med school, over-testing and doing as much as possible was all part of the training you received, right?
It was not at all on the radar screen. To be honest with you, it was much harder then to get things like a CT scan because of the availability. But absolutely, no, this was not. This would be considered best practice to
So
test.
you're looking at a big culture change for a lot of doctors, who may have been in the field for more than 10, 15 years here, to do things very differently from the way they've always done them. How possible is that?
Oh, I think it's very possible. I think that it's happening already. I mean, I think that's the success of choosing wisely and just training in general, which is emphasizing more and more the why are you doing that test philosophy. And even though my training was a few years ago, certainly I can recall some of my best teachers saying, well, why do you want to order that test? And that's the question I ask trainees now that I'm training, is to say, so you want to order that blood test or that CT scan, how is the result going to change what you're going to do? And so often the answer is it won't. And then we say, well, why are we doing the test?
Dr. Reza, when were you in med school?
2009, so a little bit more recently. Yeah, and I can definitely say that I've been the beneficiary of this, new paradigm in thinking and in approaching tests. The other thing I wanted to add, I'm really glad we're having this conversation around patient and medical culture. I think that's really important when we talk about this this problem. But one of the things we also have to consider is the way our healthcare system is designed and how some incentives operate in ways that we don't necessarily expect. So, quick example, when most people think about interacting with the healthcare system, they think about going to the hospital for a surgery or a family doctor for a checkup. But if you take a drive down any street, you might see a clinic that's dedicated to just x-rays or just blood tests in a strip mall or at a storefront location.
Yep.
And I bring this up because these clinics, the technical parlance is independent health facilities. There's about 800 to 1,000 in the province, and almost all are operated as for-profit facilities. The reason I bring this up is, if you came in and you saw me for a sprained ankle, and I was your doctor, and I also happened to be one of the owners in one of these clinics, there's a 7 times higher chance that I might order an x-ray on your ankle than if I wasn't an owner in one of these clinics.
You have hit on exactly where I wanted to go next, which is the potential conflict of interest that exists between a doctor who orders a certain test and who also happens to own a piece of one of these independent health facilities that stands to profit from more testing as opposed to less testing. How do you get out from underneath those conflict of interests?
So, I just think that is, while that's true, the reason that physicians order tests that aren't needed is much more complicated than that. And there are many factors. Patients want it. It takes longer to explain to a patient why you're not ordering a test than just check off the box. Physicians are worried about being sued. Sure, there are potentially misaligned financial incentives, but I think the most important reason's one that we just touched on in passing, which is it's about the culture. There's a lot of research that shows that you learn to practice a certain way, and then once you've learned it, you always do it that way. So if you learn to order a bunch of tests like CT scans for minor head trauma, then you always do it.
But I'm going to keep following the money here, okay? Should there be a new regulation in the province of Ontario that says if you're a doctor with the ability to order tests, that you therefore cannot own the facility where those tests are done because you have a blatant conflict of interest on that?
Steve, if I can just jump
Sure.
in. I think Wendy's actually right. This is a really complicated problem, and there's no silver bullet that's going to make it go away. So absolutely, there's a lot of different things that we need to do.
You don't like my regulation that I just proposed?
No, it is a good question because the way that these issues are regulated vary province by province. So for example, in British Columbia, unless it's the only x-ray game in town or there's an extenuating circumstances, then that's one of the things that they do regulate is they try and avoid that conflict of interest. I think it's important to recognize that, as physicians who are in these ownership structures, I don't think anyone has any nefarious intentions. No one is doing this on purpose.
It could be subconscious.
Yeah, and it's one of the many factors that can operate in subtle ways that influence the way that we can practice medicine.
I would say I think that's the minority of situations, first of all, and only one of many factors. Take another example. You could argue that if you go and see a surgeon and the surgeon chooses a more complicated procedure because that's going to pay more, is that a conflict of interest, right? I guess it could be, but I think that I wouldn't suggest that operates to any degree. We know
that in the States, though. We know that happens in the States, right, where there is a financial incentive to do more invasive surgery, and therefore it's done.
Okay, well, all I can say is I've not seen it in my environment, in my practice. I don't think that's a major driver in Canada, but I have a better solution to suggest, which is I think we need better data. I think we need to know about the tests that are being ordered. I think we need to know more about why tests are being ordered. One of the biggest challenges is this whole notion of unnecessary or appropriate. In fact, it's very difficult with our traditional administrative data that CIHI uses or even our own institute uses to judge the appropriateness or not of a test. We need better data on why tests were ordered. We need to be able to follow who's ordering which tests. If you want to look at the issue that you were raising before about conflict of interest, it'd be interesting to know who's ordering the test being done at a given facility. And I think we're starting to get there, but I think we're still living in a world where this data is very balkanized. It's very much living in silos, and there needs to be an effort to bring that together so we can better understand what's going on.
Somebody here mentioned, and Dr. Levinson, let me follow up with you on it. I can totally understand a doctor ordering a test because they're afraid that if they don't, they're going to get sued somewhere down the road. How do we take that out of the equation?
Well, I think, we think that choosing wisely, which is creating these recommendations that are made by the profession themselves, is giving support for physicians to worry less about that. In fact, there is something called the Canadian Protective Medical Association, or maybe I confused Canadian Medical Protective Association, and they think that choosing wisely will actually be helpful in supporting physicians in those kinds of claims that are maybe inappropriate. So I think that is, like I said, one piece of the culture. But I really think I want to come back to the education because, one of the things that we find is that medical students are really interested in choosing wisely because they kind of see all these things that we do. In fact, sometimes they order unnecessary tests because they want to show their attending physicians they were smart and thought of it ahead of time. And we have had a lot of students get quite involved, and they actually created an organization called Choosing Wisely STARS, which stands for Students and Trainees Advocating for Resource Stewardship. And we've brought them together, and now they've gone back to their medical schools to kind of teach their faculty, because some people have been in practice a long time, and the younger people are sort of more aware of these issues of overuse. And we think that that's starting to take root in the medical schools, and that will lead to changes in the future.
There are lots of systematic solutions, I should say, as well, which I see in my own hospital. Just as an example, overuse of urinary catheters. So urinary catheters are widely used among inpatients for all sorts of reasons, but they're overused and they lead to frequently urinary tract infections and injuries and so on. So now, in order for a urinary catheter to be put in, there has to be a written order by the physician, which before it was done sort of on protocol. Similarly, around things like urine cultures. Now, they used to be done routinely. If you ordered one type of urine test, there was always a urine culture added on just by protocol, and they've stopped that because most of those cultures were unnecessary. So there are ways of actually achieving very substantial savings and reducing this overuse of tests that are actually relatively simple to implement.
This all sounds wonderful, but I wonder, Dr. Raza, whether is this whole attempted cultural change going to get in trouble if a patient has cancer and they missed the cancer diagnosis because somebody didn't want to order the test because they didn't think it was, at the end of the day, necessary? I mean, that is the nightmare scenario here, is it not?
I will say that even well before the Choosing Wisely campaign came on the scene, medicine has always been a difficult field to work in, and there are always diagnostic challenges and cases that can even evade the most successful clinician. So do I think that this conversation about overuse, this very appropriate conversation about overuse is going to have those sorts of implications? I would be very surprised. I don't think it's going to take us in that direction.
How about the other side of the coin, which is the proverbial hypochondriac patient who insists on getting every test under the sun? He or she is not going to be very happy with this change in direction. What do you want to do about them?
Yeah, I think that goes back to one of the conversations we were having right at the beginning, and that's about building a relationship of trust between a patient and a doctor. And one of the things that commonly happens for my patients is they'll go out, they'll meet a specialist, and maybe they'll just meet the specialist for the first time. So they don't have a trusting relationship yet with them, but they soon will. But they'll come back and see me after that appointment, and they'll say, "Hey, doc, I saw the endocrinologist for my diabetes, and they're telling me I have to go on all these medications, I have to start these injections, I don't know what to do." So I often act as the translator and walk the patients through what this means. And because they've known me for 3 years, because they've seen me frequently for other things, they can feel confident in the recommendations they've received from the specialist because I'm vouching for them and I'm walking them through the treatment plan that they're going to engage in.
So they come to trust you and it works out.
Yeah, and eventually they'll come to trust that specialist, and then this sort of back and forth doesn't need to happen.
There's another aspect to that, which is that overuse of tests doesn't necessarily reduce the risk that things are going to get missed if they're rare. And when the studies have been done that have looked at clinical appropriateness in order to reduce utilization of inappropriate testing, they found that in fact there was no increase in the rate of misdiagnosis of things like head injuries and so on, significant head injuries that would result in interventions. So there is this myth that doing more tests means that you're going to miss fewer things. In fact, often you don't miss fewer things. All you do is get more false positives and more adverse consequences.
Interesting.
Absolutely.
Maybe I can come back to the trust issue, because I think that is really important, because it is really about a conversation. These are not things you shouldn't do. You just shouldn't do them when it's not needed. And we really encourage patients to feel comfortable asking their doctors questions. So we encourage patients to ask, do I really need this test or treatment? What are the downsides? What are the other options? And what if I do nothing?
Those are the 4 questions
Those are 4
every patient
questions.
should ask when they go to a doctor and they get told to take a test.
When we encourage people to ask those questions or to feel trusting to ask those questions, or at least when a doctor raises it, maybe patients will think, oh, I've heard about that more is not always better. But it is good to encourage patients to feel that they can question and have that kind of conversation. Do I really need this or don't I? That shared decision making, that's a very important part of good clinical care, is sharing decisions.
Well, let me follow up with this, because we did put all those numbers up at the beginning, talking about potentially unnecessary tests. And I guess the key word there is potentially. You may know after the fact that a test was actually unnecessary, but at the time that the kid comes in with the cut in the head, having, taken a puck off the head because they didn't put their helmet, you know what I'm getting at here, you don't necessarily know at that moment that the test is unnecessary, do you?
Well, we use clinical judgment based on the signs and symptoms. So if you see someone and they have a most likely a viral cold, you know that antibiotics are not likely going to help them. And I'm sure that Dr. Scholl has seen lots of kids hit by a hockey puck, and he uses his clinical judgment based on the history and the physical exam to determine whether he thinks that further testing is necessary.
Yeah, and that's step 1. And as Dr. Levinson was saying, step 2 is that conversation. So I've seen lots of patients sent in by other doctors for an MRI of their back. Let's say they've had back pain for a while, quite a while, or something's happened that day. They say, go to the emerged, and I'll get notes, you need an MRI. And so you can imagine the patient is worried. They are primed. They think they're going to get an MRI. And then I have the job to tell them why I don't think they need an MRI. And the fact of the matter is, you mentioned the hypochondriac patient and so on. Oftentimes the issue is, what's the real issue here? What is it that's really worrying you as a patient? What is it about the symptoms? What is it about what's going on? What is it about your relationship with your own doctor? And if you take 8 minutes, 10 minutes, maybe 20 minutes at the outside to really sit and talk to the patient, explain why you think what you think, and understand what the real issue is from the patient's point of view, you can often come up with a completely adequate resolution of the patient's concerns that don't involve a fancy or expensive test.
You got any other ideas up your sleeve as to how you can bring about this system-wide cultural change in unnecessary testing?
I think it's exactly what Michael talked about. And what Dr. Levinson has been saying. It's this idea of, some people, I've heard it being called slow medicine. There's this movement in food, from fast food to slow food, kind of a return to the roots of, our relationship with food. I think that's a pretty apt analogy for healthcare, about how sometimes to get to these issues, we have to actually get back to the basics.
As long as doctors are on fee-for-service, and I know not all of them are, but if they're on fee-for-service, they're not going to practice slow medicine. The incentives are to practice fast medicine. So how are you going to do that?
Yeah, that's a really good question.
Thank you. I thought so too.
Yes, I was waiting for it. Actually, payment reform is a really complex question, and it's something that we're constantly trying to get right. I've actually worked under 3 different payment mechanisms. I've worked as a fee-for-service doctor, I've worked as a straight salary doctor, and now I kind of work in like the Goldilocks model. So this idea of capitated, where it's a combination of a little bit of fee-for-service and a little bit of salary-style medicine. And my experience in working in all 3 models, I will say, I think it's similar to the comment I made earlier. We don't order tests based on our bottom line. Nobody does that. But these can operate in subtle ways that we're often not aware of. And I can even say that as a doctor who has worked in all 3 systems and who I think has practiced relatively similar medicine, even in myself, I've noted these subtle differences. And I think that's why I've landed in a system that works for me.
So let's finish up on this, Dr. Levinson. For the 13.5 million Ontarians who are watching this program right now, they don't all need an annual physical, right?
That's correct.
But which percentage does?
Well, people with risk factors. And that's something they work on with their family doctor. If they have diabetes, if they have hypertension or chronic disease or their particular risks, they may need to see their doctor at a different interval. But healthy young people certainly don't need an annual physical.
Did you hear that? Healthy young people don't need an annual physical. Did I hear that right?
That's correct.
Okay. We've left the people with some good information today. I want to thank the 3 of you for coming in tonight to help us understand more about this movement of choosing wisely. There's Dr. Danielle Raza, who is the chair of the Canadian Doctors for Medicare, family doc at St. Mike's Hospital, Dr. Michael Schewel, President, CEO, Senior Core Scientist at the Institute for Clinical Evaluative Sciences, and Dr. Wendy Levinson, Chair of Choosing Wisely Canada. She's a professor and past chair of medicine at the University of Toronto. Thanks so much, everybody.
Thank you.
Thank you.
Help TVO create a better world through the power of learning. Visit TVO.org and make a tax-deductible donation today.